And with that, we will get started with our session on tumor mutational burden. This will be organized similarly to our previous sessions, where we will have a presentation on analytical validity, clinical utility, and regulatory. So I'd like to introduce our first speaker. It gives me great pleasure to introduce Dr. Rosenbaum, who's a molecular genetic pathologist with the Kaiser Permanente system. He's worked to improve the detection and interpretation of structural variation by next-generation sequencing, and has also developed algorithms to calculate tumor mutational burden from targeted oncology panels. So he's well suited to talk to us about the analytical validity around tumor mutational burden by NGS. Thank you, Jason. Jason, I don't think we can hear you. At least I can't hear you.
We will go ahead and reach out to him. This is Dante with the support team.
Okay.
Is that better?
Much better.
Yes.
Okay. Got too many different ways to mute myself. Okay, so thank you, and thank you to the moderators of the meeting for inviting me to speak. As Dr. Yohe indicated, I had the opportunity actually in my last position as co-director of solid tumor molecular diagnostics at the Center for Personalized Diagnostics at the University of Pennsylvania to develop our first tumor mutational burden algorithm on a relatively small sequencing panel, and then was later afforded the opportunity as we upgraded the panel to see how the tumor mutational burden algorithm performed on the new panel. So I'll be talking a little bit about that today. Hopefully, I recognize that some of the talk could end up being too technical and might be over some people's heads, and I recognize that I might have dumbed down the talk, so to speak, and might appear condescending to others of you. So I hope that everyone comes away equally insulted. I'm not going to belabor the biological rationale for identifying tumor mutational burden. I will just say that the operating hypothesis in the context of immune checkpoint inhibition is that the more antigenic the tumor, the more efficacious the immune checkpoint inhibition will be. And since we don't have a good way in the laboratory to directly quantify the antigenicity or the number of neoantigens in a given tumor cell, a proxy for direct quantification is thought to be tumor mutational burden. That is to say, the number of mutations in a tumor should roughly correspond to the number of neoantigens produced by that tumor. As has been pointed out earlier in this summit, durable benefit from immune checkpoint inhibitors may be limited to only a fraction of patients. And it has been thought that tumor mutational burden quantification may then be a predictive biomarker of ICI efficacy in those populations that do see some benefit from ICI therapy. And the clinical rationale will be discussed by a subsequent talk. So in the early studies and in the research setting, whole exome sequencing with paired normal tissue is considered the gold standard reference method for TMB quantification. And that methodology does have some evidence to support that it works to segregate patient populations. Some massively parallel sequencing, also known as next generation sequencing or NGS panels, have documented analytical concordance between their targeted panel and whole exome sequencing based TMB scores. And you hear this a lot, or I heard this a lot when being asked to activate a TMB algorithm, that it's just counting, and it should be relatively easy to do. I'm here to tell you that counting is not just counting. And if you need an example of how you count can make a difference to the results of your count, all you need to do is look at the two houses of the United States representation. The United States Senate is counted up and accounted for in a very different way than the United States House of Representatives, and it leads to different results and different biases. So even what you might think of as a simple count depends very greatly on the underlying assumptions and the intended goals of undertaking the count. And so one example of how of that principle is sampling error, which can be illustrated by the idea that if you wanted to assess the results of a presidential election by only counting votes in Ohio, you could do that. And that would be roughly the equivalent of what counting tumor mutational burden from a moderately sized oncology panel would be. It would roughly be the equivalent of relying only on information from Ohio for the presidential election. And that is not to say that that would be useless. That it's certainly better than not counting anything. But the information is, by its very nature, limited. So the problem there is that the panel sequences less than the entire exome, which introduces essentially random error into your TMB calculation. There are a number of ways one might address sampling error. One is to simply sequence more, to not just count the votes in Ohio, but count the votes in Ohio and Oregon and Maine and Florida, et cetera. Increasing your sequencing space, though, introduces a problem of artifact filtration. And what I mean by artifact filtration is inclusive of what people would normally call a traditional artifact, like a formalin-induced artifact or a panel-specific artifact that you know occurs, for example, in a microsatellite locus. But what I'm really concerned about are artifacts introduced by bioinformatic pipelines. And the bioinformatic pipeline may be chosen for reasons having nothing to do with TMB, and it may be set up for reasons having nothing to do with TMB. But here you see an example of a variant that, with some experience, I'm not going to go over what this looks like per se, but with some experience in the sequencing space, it is highly arguable, I would say. It is very likely that you should consider, you should consider this to be a single event, particularly from the perspective of antigenicity. This would be a single event in the NF1 gene. However, due to a quirk of the alignment software and the way the alignment software was set up, the computer recognizes this as 3 separate events rather than one single event. And that by itself inflates the TMB score by 2 for this patient if you're including indels. This is particularly problematic because what you want from a TMB algorithm is to avoid having human curation of every single thing the computer is doing. That would be intensely laborious and probably not very cost effective. Another way to address sampling error is to count more things that you wouldn't normally count if you were doing whole exome sequencing. For example, synonymous variants or intronic variants if you're covering those. And the justification for doing that is that you are already identifying a proxy for antigenicity. And so the global mutation rate can in some ways be viewed as a proxy of that proxy. And it increases your effective sequencing space and gives you a larger panel effectively. The problem with doing that is in identifying the correct denominator, and I'm not going to go into the math of why that is, but it probably ends up being more trouble than it's worth in most cases. So sampling bias is a little bit of a different problem from sampling error, which is essentially random. Sampling bias is a consequence of the fact that you have chosen a certain region to sequence. And again, to use the election analogy, you'd get a very different result by choosing your president based exclusively on Illinois than you would have in the previous example of choosing Ohio. And so the content of your count makes a big difference. In cancer, that's the analogy is that the panel coverage is biased towards genes that are relevant to cancer. And that is to say, you are already looking for mutations that cause cancer. And so you are quite likely to bias your TMB high, that is, overcall your TMB from a cancer panel compared to whole exome sequencing. A graphical illustration of this is that if you had a KRAS hotspot mutation and that's all you had in your patient, whole exome sequencing would give you a result of about 0.03 mutations per megabase, effectively 0 tumor mutational burden. But a small targeted oncology panel, to make the math easy, I made it half a megabase. The exact same patient still has that one mutation because you're still looking specifically for KRAS, but the denominator is much, much smaller. And so you end up with a TMB of 2 mutations per megabase from the exact same patient. And so one way to address that is to not count hotspot mutations, to use a filtration method. And some labs use the COSMIC database to identify variants that are frequently recurrent in cancer and filter them out of TMB calculations using that database. That has some advantages. It's a very comprehensive and well-curated database. One of the problems, though, is that COSMIC, because of the way it's curated, it relies on peer-reviewed papers, and so there is something of an inherent publication bias. I'm sure we all understand that what is attractive to publish and what gets published is not necessarily reflective of biological relevance in cancer. And so another way to approach this filtration is to use something like this, the cancer hotspots database or the cancer hotspot algorithm upon which it's built, which is less biased, but it's also a shorter list of variants, and so is probably less stringent. And importantly, there's no real guidance on what the appropriate filtration strategy ought to be. And it may, to some extent, depend on the content of your panel. And so again, maybe specific to decisions that were made not because of TMB, but because of what other contingencies. There's additional noise. An oncology sequencing panel is typically performed without a matched normal comparator. The exome sequencing that I described before, the gold standard, is often performed with a matched normal specimen in order to specifically identify the variants that occur in the cancer and exclude them from the tumor mutational burden count. For cost and throughput and efficiency reasons, oncology panels are often performed simply on tumor tissue. And so they need to filter out the germline polymorphisms in a different way. And again, we turn to online databases, in this case, the GNOMAD, the Genome Aggregation Database browser, provides a list of variants that commonly occur in people without cancer and helps us filter out then variants that simply occur in the population. And this example that is depicted here is a common TP53 variant. And you can see that its overall occurrence in the population is at 66%. It's quite common. And GNOMAD somewhat helpfully breaks this down into subpopulations. And you can see that the frequency varies from population to population. But what I want to point out is that the allele count and the allele number vary from population to population too. And it should come as no surprise that Europeans, i.e. Caucasian, people of Caucasian descent, are highly overrepresented in this database. And this has real consequences. In this figure from Chang et al. From 2019, the whole exome sequencing was performed and the normal variants were filtered out, or the germline variants were filtered out by sequencing of matched normal tissue on the x-axis and simply by GNOMAD filtration on the y-axis. And you can see that there seems to be a population segregating as TMB higher than it ought to be. And if you break that down by ethnic origin or ancestry, whatever terminology you want to use, you can see that people of Asian ancestry have a fairly substantially inflated TMB. African American or people of African ancestry also have inflated TMB, although not to the same degree, but the sample size is pretty low. And this is a significant issue, that just because your ethnic background is one thing versus another, you may get a different biomarker reading. And for those that are interested, you'll rarely find a better example of structural ethnic bias than this kind of thing, in that nobody that put together the TMB algorithm, nobody that put together the GNOMAD database, nobody that sequenced the patients that went into the GNOMAD database really needed to be explicitly racist. It's just a consequence of resource allocation and an unfortunate consequence, and one that really ought to be addressed. That's my soapbox, or among my soapboxes. Adding complexity to this whole situation is that what we want to be able to do is compare one assay to another. And there is additional noise introduced from the fact that methods taken to compensate for issues 1 through 3 will vary from lab to lab due to, again, underlying decisions that may have nothing to do with TMB. TMB is also affected by pre-analytic variables, as any biomarker might be. TMB, though somewhat uniquely, is affected by every pre-analytic variable. Some examples are listed here, and it's partly because TMB is essentially a complete assessment of the tumor genome. And so low tumor purity may depress TMB. TMB can vary due to heterogeneity within the tumor itself. TMB can be depressed or inflated due to admixture with non-tumoral cells. That may sound like a way of restating low tumor purity, and in a way it is. But what I was really getting at with this point is that depending on how you do your germline filtration, a bone marrow transplant may look like inflated TMB. TMB can be inflated or depressed due to formalin fixation, which introduces artifacts and can cause sequencing dropout. This can particularly affect archival cases, which are also affected by the fact that they are not current, meaning if a patient has received treatment since an archival sample was taken, their current TMB may not accurately reflect their pre-existing TMB in the same, well, yeah, that's what I'll say about that. And as we already talked about, TMB may be inflated in patients with non-Caucasian ancestry. And so due to what we perceive to be a significant degree of uncertainty in calculating TMB, we wanted to at least convey or understand some of the level of uncertainty we were dealing with. And so on our first panel, which was about 0.6 megabases, we performed a binomial regression to estimate a TMB confidence interval based exclusively on the size of the panel. Whoops. And you'll note here that the 95% confidence interval excludes probably more variant or more TMB calls than it ought to if it's accounting for 95% of cases. And the reason for that is that it's based only on panel size and not on filtration decisions and other issues and sampling bias and things like that. And so when we did this, we were able to plot a confidence interval window for a given TMB for Assay 1. When we upgraded to Assay 2, we essentially quadrupled the sequencing size of the panel, the number of individual loci that were included quadrupled. And the TMB confidence interval narrowed at a TMB of 10 from a range of about 18 to a range of about 8. And all that took, and I put all in significant finger quotes, was quadrupling the size of the panel. Another way to frame that thought is to say that even at 2.2 megabases, the confidence interval for TMB at a TMB call of 10 was still a significant range, a range of 8. And so we went live with TMB calling in February of 2020, an inauspicious time for a lot of reasons. But the TMB was reported along with the confidence interval because we did not feel comfortable not conveying the degree of uncertainty that was present in these data. And we were also very careful to say that the true TMB may actually lie outside the confidence interval because it only accounts for the size of the panel. We were also very careful to include in the small text, the fine print of the report, that the TMB and the confidence interval apply only to the tested specimen on this assay compared to whole exome sequencing. Essentially, we're trying to convey that our validation was performed against whole exome sequencing. And the results of our assay should not be assumed to be equivalent to any other intra or extra institutional assay, even if it's performed on the same case. We were very, very concerned that, again, different decisions in assay design, either in the wet lab or the dry lab, could lead to very different TMB calculations on a different assay. So some take-home points. Counting is in fact easy, but deciding to count or deciding what to count and how can be quite difficult. The TMB calculation is highly dependent on assay design, including both wet and dry lab decisions. And the analogy I would draw here is that if you're asked to shovel a walk, you may be presented with a couple different choices of shovels. And I think at least those of us that don't live in California would land on this kind of a shovel. But there is no dedicated TMB assay. In other words, most of us, in fact, all of us, are essentially trying to leverage an existing assay that was created for other reasons in order to calculate TMB, and we may be stuck with the spade-shaped shovel. And all of that is moot if what you really want is whole exome sequencing, which would be the snowblower. It is true that statistical equivalence is often demonstrated between assays globally, but it can be biased. Things like R values can be perturbed by high TMB specimens. And so what you really want is equivalence near the clinical decision threshold, which is often highly variable, much more variable than you'd want. And so the best strategy might be to have some common reference material, as there is for peanut butter. I don't know why the National Institute of Standards and Technology settled on a reference for peanut butter, but it might be helpful to have reference for TMB. And I'll stop there, but these are some thoughts maybe for the chat or for offline discussion.